Hello, everyone. This is Dr. Khan from Executive Plastic Surgery. I want to go ahead and welcome each and every one of you, especially to the new members. Welcome to my Facebook Live. And I want to go ahead and wait a couple of minutes before I get started. I want to thank each and every one of you for being very supportive of the other members and understanding. Again, the whole purpose of the group is to help each other such that we can learn from the previous patient's experiences, so that prospective patients can understand as to what they expect when they do basically explant with me, and they also equally importantly understand how I do it and what is in my mind, my thought process, and what is my understanding and my goal of the surgery. And again, I will go ahead and highlight what is the essence of what is this explant surgery, what is the essence of the consultation, what is the essence of the whole operative experience, which is the 100-100-0 rule, which is that 100% of the time, 100% of the capsule must be removed with 0% of the capsule remaining behind, as simple as that. This is where basically where the whole gist of the whole experience is, that the entirety of the implant plus the capsule must be removed as one system with 0% of the capsule remaining behind, because we know convincingly from the many patients that have come forth that if the capsules are left behind, the patients don't bounce back. If anything, maybe their symptoms worsen. And then it is only during the second surgery, when the residual capsules are removed, the patients feel better. And so this is that commitment that the surgeon must have with their patient, such that it is very clearly documented in the consent form that the patients have a true confidence and understanding with their plastic surgeon that the entirety of the implant plus the capsule will be removed definitively by the surgeon, because the surgeon believes in his mind, heart, and soul with all faithfulness that the bounce back of the patient is truly dependent on the entirety of the implant plus capsule plus all inflammatory tissue that needs to be removed. And that is in a nutshell what is explant surgery. Now I want to go ahead and I want to wish my patient, she was scheduled today as the first patient at 6 o'clock this morning. She unfortunately last night called me a little bit after 3, and she had a fever of 103, and it turns out that she has been diagnosed officially with COVID. And so her surgery was automatically canceled. I canceled her at 3 in the morning. She did alert us. And so I wish her a very speedy recovery. She's a young lady with no comorbidities. So hopefully I wish her a good and swift bounce back. And when she's been stabilized and ready, will only then I proceed with the surgery safely and when the patient feels right. So we wish her a very speedy recovery, and all the best from us, from the executive surgery team, and also from all the other patients, I'm sure. We wish her the very best. Also, if I may mention, today I learned something new. One of my very close friends, who's a very prominent plastic surgeon, he, for the first time today, in his history of over 30 years experience, did actually explant today, where he removed the entirety of the capsule plus the implant, and 100% capsulectomy was performed. And the patient ended up getting a total capsulectomy with textured implants. The textured implants were returned to the patient, and also the capsules were sent to the pathologist. And I congratulate my friend, my colleague, for having done what would be the right thing to do, such that we will know definitively with certainty that the capsules were removed in the right fashion. And number 2, there was no residual capsules, and the capsules were sent to the pathologist, because as we know, textured implants are associated with the breast implant associated anaplastic large cell lymphoma, and the textured implants have been indeed banned, first in France and then ultimately here in the US, for they're associated with breast implant illness, lymphoma. And not only are the textured implants, but also, as you know from the implications, that the smooth implants also are associated with BIALCL. Now, what I want to do is I want to go ahead and I'm going to go over what is the plastic surgery procedure, which is basically how I, as a plastic surgeon, board certified in explantation, basically how I as a board-certified plastic surgeon and plastic surgery, Explant, and how I do it differently compared to the many others. I welcome and request other plastic surgeons to come forth and have a healthy discussion with their patients so that they can discuss with their prospective patients the mindset that they have in regards to proceeding with the surgery, so the patients have a confidence as to what and how their surgeon does the surgery, and that how does he approach each and every single case. For each single case is different from one patient to another, and not only from one patient to another, but from one side of the chest to the other. These can be two different patients. Now, having said this, what I'm going to do is I also want to go ahead and another big event happened last night where we were basically in the news once again, where Miss Clifford from Channel 7 News did come and physically interview me. She actually came into the operating room and she saw me dissect. And she also saw the capsules being cut open, and she was able to touch and hold the capsules. And it is a very special feeling. You know, here all this time she's covered breast implant illness during the 90s when they were banned in 1992. And once again, hopefully the ban occurs soon, just so that we basically understand this disease better and that no patient basically suffers from this illness. And she was able to, Miss Clifford, able to hold the capsule. She saw on what was the right capsule, it was had that calcified look and feel to it with the inflammation, the left one being less so. And she was very much surprised to see the nature and the texture of the capsule, as you will see in that news clip that we put forth, where basically I discussed the many different ailments that occur as a result of what is the capsule. Now, what I want to do is I want to go ahead and ask my listeners to please go ahead and ask any questions that you may have so that I can go ahead and answer. There were a series of questions that were asked last time, so I want to go ahead and answer them. What I want to mention is I get this asked a lot from a lot of my out-of-town patients. When they do come in, I ask that they basically, normally I do a phone consultation, and that usually is good enough. There are a lot of patients who sign up and basically book their surgery without even having had the phone consultation, but I try to catch up with each one. I appreciate the understanding of the many patients who've been waiting for the phone consultation. I have so many patients once I get done with my clinic or my operative days that I have to respond and talk to those patients who are out of town, such that I catch up with them first, and since that's my top priority. And then usually on the weekends I do catch up with the phone consultations, and so that I can answer each and every single question without any rush, and that the patients feel comfortable with all the questions. I have an interesting patient that I'm going to do what is going to be removal of a silicone calf implant. This is basically the implant that was inserted in the calf of the patient. She was a bodybuilder, and so she had implants inserted in her calf. And so essentially it's the same disease, the same physiology. And so I'm going to go ahead and remove it. That surgery is expected to be less of a challenge, given the fact that this is not going to be right off of the rib. Also, I want to mention that I have a series of videos that are going to be coming forth on my YouTube channel, given the Facebook for it basically puts a bar on any graphic videos or pictures that come forth. So there are videos that are coming forth that I just proofread today, where I show the dissection off of the rib, and very clearly, as you will see, the entirety of the capsule is literally peeled, removed, dissected off of the rib, such that there is no capsule remaining behind, which is the most intense part of the case, and that the entirety of the implant plus the capsule is removed such that there is no residual capsule left behind. It is not right, it is not proper to bovie what would be the capsule on top of the rib, saying that that is the best I can do, which is unfortunately what some of the surgeons say. It is improper and incorrect to say that the capsule is going to get disintegrated or enzymatically broken down by the body. The capsule must be physically eliminated, removed from the rib, essentially peeled off, which is the fascia of the intercostal needs to be physically dissected off, such that the entirety of the capsule is removed definitively. It cannot be bovied. Another analogy that I've given in my many Facebook lives is if you cauterize or burn the capsule on top, it's like, or analogous to, the grill that you basically leave the barbecue on. You still have the residual capsule or the specimen left behind that will continue to haunt and hurt. So the capsule must be physically eliminated with intense microdissection, such that the fascia of the intercostal and the perichondrium of the rib be removed, such that there is no capsule left behind and there is no burden left behind that will continue to trigger what would be the breast implant illness. Now, what I want to do is I want to go ahead and ask, and again, I'm trying to see, in the comment section, I'm going to go ahead and go onto my other phone and see if any of you basically will be able to ask me any questions that I can answer. So if you can give me a few minutes here, like a minute here, let me go ahead and see how I can look at the questions. I also want to stress and highlight the fact that what is the procedure that I do, or everyone has been lately talking about, is the Khan procedure, which basically is how I do it differently compared to the many other surgeons. The number one, I return the implants to the patient. This is very important, so the patients can see that the implants were intactly removed, that what is the consistency of the implants, and that they basically reflect the same. It reflects the same on the card that the patient usually receives when they got the implant. Number two, I do not do drains. So far to date, I have not used a single drain on any of my patients. Almost 100% of my the saline patients, I have not used drains. This is the very tedious, meticulous dissection that I do directly underneath the muscle, majority of the times, or on top of the rib. Or in those cases where the implant is placed above the muscle, the dissection is done in a very nice, sophisticated way, such that the need for the drain is not there. Also, in the many patients where I have done, the implant is ruptured and there is silicone that is essentially basically broken the shell of the implant itself, I've been able to dissect very meticulously, such that there is no spillage within the chest cavity, and as a result there is no need for the drain. I've been able to contain the silicone that might have ruptured through the lap sponge or suture that I might put, and the entirety of the operation is done in a very sophisticated way, such that there is no spillage. If there is any spillage into the chest, automatically there is mastitis or silica mastitis that occurs, or inflammation, and that automatically buys the patient a set of drains, because we don't want that inflammation to continue to produce or to irritate the skin and also the breast tissue, that will basically cause a lot of fluid buildup, and hence the drain is required in those situations. So number one, I give the implants back. I don't use drains. I have not used drains at all this year. Last year I used drains only on 3 people, and I've had a consistent basically record, basically safely doing the surgeries in this fashion. Number 3, I don't do lifts. Majority of the times, 80% or so of my patients do not need a lift. And the way I've been able to do it, I dissect very cleanly, very clearly, directly below the muscle, such that I'm in that avascular plane. And what happens is, when the implant is physically removed, the muscle sticks to the rib, and that automatically causes what would be a pseudo elevation of the breast tissue, and as a result the need for the lift is not there. And the vast majority of the cases, even ladies that are in their mid-50s, postmenopausal, with little elasticity of the skin, I've been able to get by. And this is the day where, when I do my explant, that is strictly reserved for those cases where the 4-hour block time that I do, sometimes 5, sometimes 6 hours that I've spent, but on average 4 hours, that entirety of the time is left to dissect below the muscle, such that there is no capsule remaining behind. The lift operation is all above the muscle, where you have rearrangement of the nipple areola. The right word is the mastopexy, and that in itself is at least a 3-hour operation in order to do what would be the lollipop incision and an anchor. And this is where I wholeheartedly believe that you cannot do a explant below the muscle where removal of the implant and capsule is done, along with what is a mastopexia lift above in 3 hours. That's virtually impossible, where I myself just take on average 4 hours just to remove the implant plus capsule below the muscle. Number 4, I take cultures from the right and also the left chest, send them off to the microbiology lab for aerobic, anaerobic, and fungal cultures. As we all know, the implants are associated with bacteria, acne bacteria and other bacteria that basically seed the foreign body, the capsule, so that it is integral to know. And I'm very happy to state to date I have had 0 infections so far. Also, the fifth thing that I do is, which is unique, I send the capsules off to the pathologist 100% of the time. This is this disease, the breast implant illness, that continues to cause and be detrimental to the patient's health. These are patients who have seen almost 10, 15, 20 different types of doctors over the years, maybe some as little as 1 or 2. Even their primary might have done an extensive workup that yields nothing. And ultimately, we want to be able to get and capture and confirm the definitive certainty that the BIA, breast implant associated anaplastic large cell lymphoma, is not there. The CD30 analysis is done by the pathologist. The pathologist also can look under the microscope and confirm that there is no mold or there is no malignancy, there is no breast cancer, and that is integral and important to rule out, which is an important test. Number 6, also, that what I do is I utilize what is twilight anesthesia. In a nutshell, there's 2 general types, which is when someone gets a colonoscopy, for example. This is the TIVA, or the deep sedation, where you can hear the patients are actually in deep sleep and they're monitored by the machine, the same machine that does general anesthesia. There is no paralysis and the patient essentially is breathing on her own. This is as opposed, and the patient has no recollection. She's not awake. She's totally in deep sedation. She has no idea as to what is going on, and she's in a very comfortable, safe environment in the sense that their vitals are being monitored. This compared to general anesthesia, where you have paralysis of the body, and the chances for DVT are certainly there, along with positive pressure ventilation, among other problems that may occur as a result of what would be overkill anesthesia, I would say. This is still outpatient surgery in the United States, and this is a surgery where when there is an efficient, more robust and efficient system and a proven way and the safer way, this is the way the anesthesia should be delivered. Last but not least, it is important for the patients to get like a good feel and comprehension, and they should certainly proceed with surgery with a surgeon who does exclusively explants and who has a proven track record of basically having a social media following, because this is something that is not described well in the books or the textbooks or even at the conferences, and this is still very much in its infancy. And this is what I say, this Khan procedure that everyone's been talking about, and they have coined this term even before I acknowledged or I knew about it. The fact that 20 years from now, I cannot imagine anyone else doing the surgery any differently. And that fact is all what I'm doing and ensuring, if you look at it in a nutshell, is I'm ensuring complete and comprehensive and total removal of the capsule plus the implant, such that 0% of the capsule remains behind. For this is where the patient's bounce back and success lies postoperatively. Now I want to mention that, I am a big fan of DNT, which means do not touch. I don't like any unnecessary surgery, be it a hand surgery that I do or any surgery that basically does not require, or we can easily, safely, and effectively basically get away with not doing the surgery. And with what I mean by this is as essential surgery can get, which is non-cosmetic in nature. And I say the explant surgery is essentially as uncosmetic as a surgery can get, because you can imagine why the patient got the implants to begin with. And look what we're doing, or what I am doing on the day of the surgery, where I'm removing the implant at the expense of what would be the cosmesis. And majority of the times, I would still say many patients are still very much surprised how aesthetically pleasing and how the chest looks despite having removed a significant volume and where you have a natural feel. And again, the whole purpose of the operation is to basically make the patient feel better and healthier, such that she is void of all those symptoms of breast implant illness, and that she has a bounce back to her normal and natural quality of life, her psyche, and what we know of all the breast implant illness problems that are associated with the implants. Also, if I may mention, this is very important, the FDA did highlight the 3 problems, i.e. that are important to acknowledge and to bring forth, and this is what was my letter to Lansing, the Department of Health, clearly outlining the many detrimental effects of augmentation, and that we know very clearly that the implants, number one, and this has been highlighted by the FDA, number one, the implants don't last in the body forever. Their report, the FDA clearly mentioned that the implants last in the body on average 10 to 15 years. And I say the breast implants on average last 7 to 10 years, sometimes as early as 5 months, sometimes as early as 2 years that I've removed implants where they started to react negatively and the patients were now seeking explantation. Also, the second thing that was highlighted, that the implants are associated, both textured and smooth implants, both are associated with breast implant associated anaplastic large cell lymphoma. And to date, only 733 such cases have been reported. And the FDA acknowledges, along with the many plastic surgeons, that this is certainly very much underreported. For many surgeons are not sending capsules off. I request my listeners and to spread the word that the plastic surgeons, whoever explant, must send the capsules off, because we want to confirm with definitive certainty that there was no lymphoma associated. I have had a few patients that have had positive lymphocytes, suggestions of CD30 positivity, where I've sent them to the Carmanos Cancer Center, where the cancer center, which is the #1 cancer center here in the state of Michigan, has processed and evaluated, and another second thought, a second opinion by the pathologist weighing in, confirming that this is indeed not what is lymphoma, because it is absolutely associated with implants, especially the textured, and that this is for this reason France and ultimately the US led to a ban of what is textured implants. Last but not least, we all know that the breast implant illness is very much real. It's been reported by the manufacturers. It's been reported by the many ladies, the 142,000 or so that are currently on the Nicole page, who has done, that clearly highlight what is breast implant illness. We also know this from the big MD Anderson study that was published in the Annals of Surgery, and I'll go ahead and highlight this on the private Facebook page, which basically looked at study of studies that basically show that 100,000 patients who had implants, 80,000 with silicone, 20,000 with saline, that these patients had, detrimental effects of Sjogren syndromes, which is dryness of the eyes. They also had rheumatological issues, scleroderma. They also had other issues, problems such as stillbirths, which were significantly elevated compared to the average population. Also, a significant risk, 8 times higher, of rheumatoid arthritis in patients who had implants compared to the average population. And again, this is a study of studies and published by the group out of MD Anderson, which is the #1, #2 cancer center of the US, and a very reputable study. It certainly has a lot of information, again, reflecting what is highlighted by the FDA. So this is a very serious study that kind of indicates the negative effects of what we know of what are breast implants. Now, again, I'm looking at the comment section. If you can please ask any questions that you may have so I can go ahead and answer to the best of my ability. I get this question a lot. I'm coming in from out of town. What and how should I plan my surgery? And I would say that plan on leaving at least post-op day number 6 or 7. So, for example, if your surgery is on a Tuesday or a Wednesday, you plan on leaving the following Monday after you're seen by me in clinic. Ladies, for example, that have 835 cc implant, that is 35 more what would be the maximum amount. We know that the dissection is going to be much more intense. The third spacing is going to be much more intense. then that basically buys the patient, relatively speaking, a longer stay. I request that the patients get basically flight insurance such that when they do, if they do change their plan, that they will not be penalized. I request that the patients also, as far as take into consideration the many other comorbidities that may have. For example, a lady that came in and she had juvenile rheumatoid arthritis since age 5, and she was on prednisone and other also immunomodulators. You can imagine her healing is going to be different compared to the other 55-year-old who was not on these medications. A diabetic or a hypertensive, certainly, along with other patients who have other issues that basically may complicate or may essentially necessitate a longer basically recovery. Another patient that I met recently, she has had implants for the last 47 years. 47, yes, that is correct, the one and only. I can tell with absolute certainty she's going to have a rupture. Another lady that I just talked to today, she has had implants from 1984, the one and only set, and I can tell you with certainty she, just by looking and listening to her history and from the time she had the implants, that's much older technology, so very likely she's going to have a rupture on both the sides, and there is certainly a possibility relatively higher in her that she will end up in drains if she has free floating silicone, especially if she comes in with pain. Now, so I always ask my patients to go do your homework, be assertive, be nice, but at the same time, ask your plastic surgeon the questions how serious and motivated they are into removing the whole capsule, because that's essentially what is explant surgery. It is a very serious operation, and it is an operation that many plastic surgeons will not undertake if they feel uncomfortable dissecting on the chest wall. For example, if your surgeon does not feel comfortable putting in a chest tube, I can assure you with certainty they're not going to be brave or bold enough to removing the entirety of the capsule, because there are indeed many times where the surgery is very intense, and even in the many cases that I do, but I know in my mind that is what it takes for the surgery to be done correctly, such that there is no capsule remaining behind. So if your plastic surgeon feels uncomfortable putting in a chest tube, he or she will not undertake the challenge of doing the dissection off of the rib, so that they don't want to take the chance of potentially running into complications or problems. There are 5 things that I've mentioned before that are very important, that essentially what I used my criteria, the Khan criteria, that basically indicate or point towards basically a good explantation. Number 1, the length of time it takes for the surgeon to do the surgery. If the surgery is done in an hour and a half, I guarantee you 100% that surgery was not done right. It takes me on average 4 hours, and I would say I'm relatively fast when I use the word fast in the sense that I move in a very efficient, quote, I would say slow way. And that's what it takes. It's not a matter of being fast. It's a matter of being efficient and very proficient, and also very meticulous and tedious in the dissection, and to have that patience in order to dissect off of the rib. If you cannot do the surgery in less than what I would say on average, which is 4 hours. Now, there are times where I've done faster. There are many times that I've done over the 4 hours, but this is important. The length of time, on average, 4 hours. Number 2, the length of the incision is dictated essentially by the diameter of the implant. So you cannot have a small incision and removal of the entirety of the implant and capsule from what would be it saline or silicone implant, which is 3 times the size, or you cannot make an incision through the nipple areola and remove the entirety of the implant without rupturing the implant. And this is why it's critical to see the implant in itself. Number 3, you want to go ahead and see pictures of not only the implant plus the capsule on the table, but more importantly and equally importantly, the pictures of the chest wall showing that the entirety of the capsule has been removed, such that there is no other way of proving that the entirety of the capsule was basically removed definitively, and that because you're visualizing the chest wall and also you're seeing the capsule. Number 4, you want to make sure that the reputation of the surgeon is also taken into account. And I just saw this question: how many surgeons or surgeries would you consider be an expert in this field? So I will tell you, it's not only the number. There are some surgeons that I know that have done 100, 200, 300, and I would say they're not proficient at all, because I wouldn't consider them, number one, to be board certifiable, or they don't truly comprehend, and they pick and choose their surgery, or if it's a thin capsule, they leave the capsule behind. I would only consider two other surgeons who have met, at least in my mind, through word of mouth and anecdotal and social media and other patient feedback, given the nature and level of the surgeries that they do. It is Dr. Chan out of California and Dr. Feng out of Cleveland. Otherwise, I don't have any confidence in any of the other surgeons, unfortunately, just given the nature and length of the dissection and how they pursue. And this has also been echoed by the many other surgeons. There is no video conference, there is no video proof, there is no other proof. Unfortunately, in today's world and age, believe it or not, if I am a no-name surgeon, I can pay some of the Facebook websites, and there's ample evidence. I've gotten a lot of these emails. I have gotten a lot of Instagrams, Facebook private messages that say, please donate to my Facebook. I will then promote you on my Facebook page. So you have to be very careful. You will see there are plastic surgeons who have donated $3,000, $5,000 on a routine basis, and they continue to be highlighted on the Facebook pages. They get the asterisks, they get the highlighted recommendations by these Facebook group owners who have no understanding of what surgery is. And then they say, proceed with caution, use your own experience, ask the right questions, which I have to say, it's total unprofessionalism and absolutely not fair for the patient, because they do not want to travel, or they feel that they have the confidence of the Facebook live or the Facebook group numbers, which is absolutely incorrect. Also, I want to mention, if your plastic surgeon is saying that they're going to go ahead and process the explant through your insurance, that is absolutely a big red flag. That is absolutely not going to be where the insurance company is going to reimburse, but only a few $100s. Just today, there was a reimbursement for $453 that I signed for, that the patient got reimbursed. This is not the amount of dollars that the surgeon will take. This is where the surgeon will rupture the saline implant, remove it in 20 minutes, half an hour each side, and be done in an hour, hour and a half. And that is what is unfortunately happening, where the patients are happy, oh, my plastic surgeon took my insurance. But I will tell you with absolute confidence, you are not going to get something like a 4-hour commitment and get the plastic surgeon reimbursed professional fee only a few $100, $500, $800, $1,200, which is basically on average what I find from the patients that continue to process through themselves, because the insurances nowadays don't work for the patients at all. You know, be it cancer, believe it or not, basal cell cancer, I wanted to go ahead and do artificial skin. The insurance denied. They said, well, you should just do a skin graft, that's easier. Or they started dictating through their family medicine doctors, coaching the plastic surgeons as to how to do the hand surgeries, and essentially putting bottlenecks. And we all know this, where the insurance companies are there to make money at the expense of the patient. And certainly the hospitals too, they are out there to make money at the expense of the patient. And and this will be a topic on itself, we all know people who work in the medical field, who work within the hospital administration, who work for the hospital, and the many physicians unfortunately are told and dictated, and they unfortunately give up their professionalism in a pursuit for what would be a financial reward at the expense. So basically that means putting stents in the heart of patients, in the hearts, for example, and the stent is not truly required, or doing unnecessary procedures or x-rays where they may not be needed, just because it basically adds to their financial incentive. And we all know this for the many patients who work in the medical field. The medical world is replete full of these situations, especially now where the medical insurance, the insurance companies don't reimburse the doctors or the hospital, and they put the burden on the patient for their co-expenses, or they put the financial burden essentially of what is the number one reason for bankruptcy in the United States. And again, I'm not trying to be politically correct. I'm just trying to be realistic and honest. You're looking at, for example, a colonoscopy will reimburse a gastroenterologist here in the state of Michigan $205.76 by Medicare. This is not how a doc is going to. And you're going to see that there's been a major shift from private practice into hospital-based or group-based medicine, where they're able to negotiate with the insurance companies a better reimbursement. The solo practitioner days are over, and anyone who's practicing solo or charging insurance absolutely is a big red flag. And 100% of those cases are basically not done correctly. They're only done incompletely with residual capsule left behind. So I tell all those listeners to be very cautious and to be very, very careful when they proceed. I have mold toxicity symptoms. Now, if you look at, mold is something that does not grow within the implant. This is not the right environment for mold growth. This is relatively very unusual, but that has been seen, has been reported. I have reported patients with positive mold cultures that I've sent to infectious disease, and they still do basically nothing about it. They have not gotten long-term treatments, but this is important to confirm. Sometimes a patient may get fungemia for other reasons and may end up necessarily seeding the implant. That may be the secondary reason how the mold may basically have gotten in the proximity of the implant, but still important to rule out. Now, the other thing I may want to, what made you start believing in BII? Look, when I was one thing I just want to correct, when I was a medical student in Chicago, I did rotations, my plastic surgery rotations at the Cleveland Clinic. I rotated at the Sloan Kettering for my thoracic surgery rotation. I spent a year in Boston in a cardiothoracic lab, and I had all the time in the world in between my cases, depending on what I was doing in the research lab, to spend time in the operating room with cardiothoracic surgeons, general surgeons, surgical oncologists, and plastic surgeons. And it doesn't take much. If you bring from being a medical student, and then when I was in residency training, this is when I was at Yale. This is unlike what the news clip said. I said that in error. When I was at Yale, I matched categorical at Yale at this Yale surgical program in Connecticut. And then that's where my real insight into what is breast implant illness started. This is the time when one of my professors, his wife ended up getting a breast cancer, and he was a surgical oncologist. And I was a surgical resident and intern on that case for that month. And I asked the surgeon, how come you're not having your wife get the best reconstruction, which would be an implant-based reconstruction, which is done in 90% of the patients who end up getting breast cancer. And he told me about all the detrimental effects. And at that time, in 2003, when I was at Yale, from 2003 to 2007, this is where I learned of the negative effects of silicone. And this is the time when the silicone was banned. We all heard of the ban in 92 that was basically as a result of the silicone toxicity, that what we are seeing again. Now, it doesn't take much for you to see and hear one patient after another. This is that recurrent theme of breast implant illness that basically leads you without a doubt. Just imagine you go to the Nicole Facebook page, or you go to my Facebook page, and you just listen patient after patient after patient. And this is where I've told the FDA, I've told Lansing, I've told the Department of Health, come here and spend some time with me on a Monday, and you will hear the patients themselves screaming in pain and in misery and in basically all the discomfort that the breast implant illness causes as to the negative effects. And then you can see a dramatic improvement in their health within hours. Look at the last video that I posted, and you see the major effects, the negative effects are all of a sudden gone. And this is to date not a single patient who's explanted who is basically truly couldn't have been happier as a result. And this is basically, you put the two and two together, and it doesn't take much to realize that the implants have been detrimental to the body. Now, there are many reasons why implants are bad. Now, I'm going to go ahead and highlight the many reasons. Number one, this is an elective procedure. Number one, this is the elective procedure where majority of the implants are placed below the muscle. imagine compromise of the pectoralis major, which destabilizes the anterior shoulder, the shoulder, which is basically where the pectoralis inserts into the humerus. So number one, you've compromised the pec function. Number two, ladies who get mammograms, they're afraid to get mammograms because of the pain. They're afraid of rupture, and guess the mammogram is not being done. And now 1 out of 8 or 9 women who have potentially the prevalence, the incidence of basically breast cancer, you're missing now on patients who had cancer being picked up because of a good mammogram. Number 3, the mammogram gets in the way, so the studies are not the best of the studies. Number 4, the implants are associated with capsular contracture. They're also associated with infection. They're associated with asymmetry. Remember, the implants don't last in the system forever. The implants are associated with anaplastic large cell lymphoma. The implants are associated with the dissection that is carried out around the breast tissue for those ladies that have had reconstruction above the muscle. Now, all of a sudden, you have had dissection in and around the nipple areola, which cuts or compromises the ducts and leads to scar tissue, which may sometimes lead to unnecessary biopsies because there was residual scar from what would be a stitch granuloma that was notable before. So the effect of the implants are so vast and so negative. I said I don't want to do something where, let's say, if a young lady in her 20s gets implants, you can imagine if the average American woman lives to 82, she would theoretically have had to change her implants 6 times at least in her lifetime, amongst the many other reasons why she would have had to go in maybe sooner, or trauma to the chest, for example. So there are many, many, many reasons why augmentation is not good, and plastic surgery has 3,000 operations. It is by far, as I mentioned in the news reporting yesterday, the #1 procedure that is done by plastic surgeons. Not even liposuction or the other surgeries come close, because it is by far what would be the most financially rewarding operation in the least amount of time, where in 45 minutes to an hour, 15 minutes, you can be done with an augmentation. And the point I'm trying to make here is do no harm, and that is the Hippocratic Oath. We know that the implants have been banned, and we know why should we do a procedure and that, yes, certainly has aesthetics to it, and the bottom line here is it is not worth it, period. It is not worth the misery. It's not worth that temporary gain, that temporary honeymoon period that the patient may have, or sometimes it's these outside forces, i.e. the significant others, that may be dictating that the patient get implants. Otherwise, their social life may not continue, and unfortunately, there are a lot of patients that basically present in that fashion. So now I want to go ahead and answer a couple more questions, and then I'll go ahead and wrap this up if that is okay with the team. There's a lot that I talked about. What I want each and everyone to do, the best resource that you have is you have to do your homework. Talk to the old patients of the surgeon that you're interested in. Have the surgeon vocally come out and say breast implant illness exists. If someone says, I don't believe in breast implant illness, or I saw an operative record where the patient said possible breast implant illness, how on earth is that surgeon going to remove the implant with definitive certainty? How is he going to be or she going to be convinced? There is no point rupturing the implant on the chest and then removing it so that it's done easy or the incision is small. If your surgeon is fixated on the length of the incision, then that is not your surgeon. If your surgeon is fixated that the insurance will reimburse and you're not worried, that's not your surgeon. You need to talk and do a check and balance on me, check and balance on every other surgeon, so that when you go in, you have that confidence, you have that peace of mind that you are getting what you are signing up for, which is, again, I will highlight the 100-100-0 rule. 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind, because this is where the bounce back lies, period. In a nutshell, this is what is explant surgery. Your surgeon must have that track record where he has or she has done so many surgeries in a very sophisticated way, where you have had surgeons basically perform the surgery such that there is no negativity left behind. Look, there's a surgeon who did an explant. She did not get better. This is a nurse. And lo and behold, she knew deep down within with conviction that this was a surgery that was botched. And guess what? She goes to a surgeon in Ohio. The Ohio surgeon takes her under the knife. There is an operative record from the first surgeon that says that total capsulectomy was done and that implant was removed along with the capsule with definitive certainty. Now this patient goes to this other surgeon in Ohio and gets the explant surgery re-evaluated, and there is not only residual capsule but muscle that has been irregularly or dysfunctionally repaired. You have a track record of a surgeon who basically is basically all over the internet claiming to be the explant specialist, but guess what? Paying herself to be marketed effectively. And this is where you have to proceed with caution, where you have to say with certainty, yes, my surgeon has that confidence, I have the confidence, and the surgeon has the confidence that they will do the surgery right. You have to have that faith. You have to have that sixth sense call, like feel that you feel comfortable into committing with that surgeon. You have to feel. And now I will tell you, one patient from South Dakota, a mom of 5 kids, she signed up with me, and within 3 minutes, she's like, I'm coming. I said, this is too fast. You're probably going to change your mind, ask me more questions. She told me 2 things. She said, number one, you are basically removing the entirety of the implant and capsule, and you have a proven track record, and the fact that you have a following on Facebook Live, you cannot do this and say this. And number 2, the fact that you as a board certified plastic surgeon, you have not augmented in your career. And I said, I'm proud to say that, and I'm humbled to say that, because I don't want to harm anyone. He said that in a sense basically puts to rest all. And as you will see across the country, I talked to Nicole out of British Columbia. This is the breast implant illness support group with the 142,000 patients. And I said, Nicole, you need to please come up with a list of surgeons who are only explanting and they don't augment, because you know what? That's your real list, because that's your list where you can say with confidence, with harmony, with all mental satisfaction that these are your go-to surgeons. And lo and behold, now you still have to be careful and you have to vet them out. You have to be certain that your surgeon is doing a good job, because technically many people claim to be, well, I'm going to do the best job. But guess what? When the going gets tough in the OR, the surgeon walks away or says, you know what, for the betterment of the patient, I'm going to go ahead and leave the capsule behind. You don't want to be that patient, because that's where you're going to be ending up hurting afterwards and maybe going to another surgeon for definitive residual capsule removal. So the heavy metal part report, is basically a mass spectroscopy biochemistry type of a workup evaluation. The pathologist will not check for heavy metals. You could be living in the Gulf and be exposed to a lot of fish and whatnot else, or you could be in Flint where you have a lot of lead or whatnot else toxicity. And again, this is a topic in itself. You cannot put the 2 and 2 together. You could have had a lot of toxicity just by environmental exposure. Anyways, with this, I wish each and every one of you, I kind of summarized everything that I know, how I do what I do. Please be on the lookout for those YouTube videos that are going to be coming out shortly, so that you have that education as to what happens. Now, there are some ladies, and I'll end with this, that feel that they are not comfortable watching. Sit with someone who's in the medical field, or at least look at some, so that you truly comprehend what is informed consent, how I do it, so you comprehend what is an en bloc. There is a video that I have on YouTube that I explain en bloc, 100% total capsulectomy, partial capsulectomy, a capsulotomy. You want to be well versed and you want to feel comfortable talking to the previous patients and also your surgeon, that you need to have a bond with and the confidence, so that when you sign up, with absolute certainty there's going to be no surprises post-operatively. Anyways, having said this, I wish you all the very best, the best to you all. Please continue to keep asking questions, and till next time, all the best. Thank you.